Welcome to the Digital Pathology Podcast, Trailblazers. So I want you to imagine this scenario for a second. Your patient with head and neck cancer just finished this, grueling course of neoadjuvant immunotherapy.
Oh, yeah, which is incredibly tough on the patient.
Right, super tough. So you send them in for their standard follow-up CT scan, and the radiologist report comes back with just devastating news.
Let me guess, the tumor looks massive.
Exactly. The tumor is massive. It looks like it's growing, pushing into surrounding tissues. Basically, it looks like a catastrophic clinical failure.
But then, and this is where it gets crazy, a few days later, the surgical oncologist actually removes that tissue.
Yeah, and the pathologist puts the slide under the microscope, and a completely different reality emerges. The scan was lying. The cancer is 100% dead.
I mean, it's one of the most jarring clinical scenarios we encounter today. It is fundamentally fracturing our reliance on traditional imaging.
Wow, yeah. It's a total disconnect.
Totally. We are seeing this complete disconnect between microscopic radiology and microscopic reality, which means pathology is no longer just confirming what the scan saw,
Right. Pathology is stepping in as the definitive, ultimate source of truth for patient response.
Exactly. It's a massive shift in how we practice.
And that discordance is actually the foundation of our Journal Club deep dive today. We are unpacking this really paradigm-shifting paper.
Annabelle's paper is fantastic.
It really is. It's titled Modern Pathology-Driven Strategies in Neoadjuvant Immunotherapy for Head and Neck Squamous Cell Carcinoma. This comes to us from Annabella Mauro and her brilliant team, and it was published recently in the MDPI journal Cancers.
So the mission today for the Trailblazers listening is to explore how we are aggressively moving away from that legacy anatomical staging.
Right, moving away from just measuring size and moving toward high-resolution, biology-driven response assessment.
Yeah, and to really appreciate the magnitude of this shift, we have to look at the historical failures in managing locally advanced resectable head and neck squamous cell carcinoma, or HNSCC.
Because historically, the standard of care was just upfront surgery.
Right. But operating on the jaw, or the base of the tongue, or the larynx, it carries profound morbidity. I mean, it compromises the most fundamental human functions.
Breathing, swallowing, speaking.
Exactly. Because of that severe anatomical real estate, the field pushed really hard for neoadjuvant induction chemotherapy to sort of downstage the tumors before the surgeon even intervened.
But the data on induction chemo was, incredibly frustrating.
Oh, deeply frustrating.
When you look back at the major meta-analyses, neoadjuvant cytotoxic chemotherapy consistently failed to deliver a definitive overall survival advantage over upfront surgery.
Yeah, it basically poisoned the patient and delayed surgery, but it didn't fundamentally alter the survival curve.
And a huge piece of that failure, which the Mauro paper really highlights, was our reliance on RECIST criteria.
Right, traditional radiological endpoints.
We were essentially using a tape measure to evaluate this complex biological war zone.
That's a great way to put it. We were measuring the shadow of the tumor, not the biology of the tumor.
Measuring the shadow.
Yeah, and then the advent of neoadjuvant immune checkpoint inhibitors completely altered the microenvironment.
Because it's not just a generic cytotoxic event anymore.
Exactly. Instead of just inducing something that shrinks a mass, immunotherapy like PD-1 blockade unleashes the patient's own endogenous T-cell repertoire.
You are recruiting an army, basically.
Right, an army of CD8 positive T-cells, dendritic cells, and macrophages straight into the tumor bed.
And all that activity takes up physical space.
Exactly. This massive influx of inflammatory cells combined with the subsequent edema, neovascularization, and dense stromal remodeling, it physically expands the tissue.
Which brings us to the phenomenon of pseudoprogression.
Yes, the bane of radiologists everywhere.
I actually like to frame this radiological deception as the Trojan horse effect.
Oh, I like that. How so?
Well, when the radiologist looks at the CT or MRI, the imaging modality is really only capable of measuring the giant wooden horse.
Right. It just sees the structure.
Exactly. It detects this massive, swollen, inflamed structure and categorizes it as stable disease, or worse, progressive disease. But the scan is completely blind to the Greek army inside.
The thousands of activated lymphocytes.
Yes, the lymphocytes that are swarming inside the architecture and systematically dismantling the squamous cell carcinoma from the inside out.
That is a perfect analogy. The scan quantifies the volume of the battlefield, not the volume of the remaining enemy.
Oh, that's good. The volume of the battlefield.
And that biological reality elevates the surgical resection specimen to Just an unprecedented level of importance.
Because it's not just anatomy anymore.
Right. In the era of neoadjuvant immunotherapy, the resected tissue isn't just a piece of meat to be staged for a static report. It serves as an in vivo readout of the patient's unique systemic immune response.
The tissue captures the precise mechanism of immune-mediated tumor clearance that the macroscopic imaging entirely misses.
Exactly. So if we accept that the scans are essentially compromised by this inflammatory response, the entire burden of proof shifts to the pathologist.
Right. We need a totally new metric. We can't use size, so we have to use cellular viability.
And that's where the Mauro paper emphasizes a pivot to quantifying residual viable tumor, or RVT, as the new gold standard endpoint.
So we are meticulously calculating the exact percentage of living metabolically active carcinoma cells that are just remaining within the treated tumor bed.
Yes. Establishing a standardized quantitative metric like RVT is critical for trial design and, well, prognostic stratification.
And the pathology community has established some very specific thresholds for this, right?
They have. So we look for a pathological complete response, PCR, which is defined as absolutely 0% viable tumor remaining.
The Holy Grail.
Right. But equally important is the threshold for a major pathological response, or MPR, which is standardized at less than or equal to 10% residual viable tumor.
Wait, 10% or less?
Yeah. Hitting that MPR threshold, even with a tiny fraction of rogue cells persisting, strongly correlates with exceptional long-term disease-free survival.
So let me push back on the physical mechanics of that 10% threshold for a second, because it's highly counterintuitive to me.
Okay, how do you mean?
Well, if an oncologist hears that a tumor has shrunk from 100% viability down to 10% RVT, the natural assumption is that the tumor melted away from the outside in.
Ah, like an ice cube.
Exactly, like an ice cube melting on a warm countertop. You just find the tiny, concentrated little sphere of ice remaining right in the dead center of the tumor bed, measure its diameter, and you're done.
Yeah, that makes sense logically, but the paper makes it clear that this centripetal contraction model is entirely wrong in the context of immunotherapy.
Wait, really? It doesn't shrink from the outside in?
Not at all. The ice cube model works relatively well for targeted therapies or rapid cytotoxic events, but immune-mediated clearance is vastly more complex.
Okay, so what does it look like then?
The Mauro paper highlights this incredible morphological phenomenon known as the starry sky pattern of regression.
Starry sky. That sounds almost poetic.
It is, visually. Under the selective pressure of a mobilized immune system, the tumor does not shrink uniformly. The T cells actually infiltrate along vascular tracts and fibrosepta.
So they're like tunneling in.
Exactly. They're actively cleaving and fragmenting the main tumor mass. It breaks apart into these scattered microfoci.
Wow.
Yeah, isolated microscopic nests of viable carcinoma hidden across this vast expanse of therapy-altered stroma.
So they're essentially tiny islands of survival in a sea of inflammation.
Precisely. Which means if a pathologist just takes a standard macroscopic cross-section from the geometric center of the tumor bed,
They're almost guaranteed to miss these scattered stars.
they will. And they will report a PCR when the patient actually still harbors scattered residual disease.
Which could be a fatal mistake for the patient's adjuvant care.
Exactly. That sampling error is the greatest risk in modern oncologic pathology. Meticulous, comprehensive, whole specimen tumor bed mapping is absolutely mandatory.
You have to embed and evaluate the entire macroscopic footprint of the original tumor site.
You do. And to accurately map that footprint, you really have to recognize the tissue that has replaced the cancer. We are evaluating immune-related regression beds, or IRBs.
And the Mauro paper goes into incredible detail on the histology of these IRBs, right? The contrast with historical treatments is just fascinating.
Oh, it's night and day.
When we used to look at tissue post-platinum-based chemotherapy, we saw this, like coagulative, infarcts-like necrosis.
Yeah, just a desolate wasteland of ghost cells and dead tissue.
But these immune-related regression beds are the exact opposite. They are hyperactive, living structures.
They really are. The tissue left behind by a successful immune response is highly organized. An IRB is characterized by active proliferative fibrosis, prominent neovascularization forming new capillary networks.
And didn't they mention massive collections of cholesterol clefts?
Yes. That happens where the lipid-rich membranes of destroyed tumor cells have essentially precipitated out.
That is so cool.
It is. But most importantly, these beds are packed with dense, organized CD8-positive T-cell infiltrates. They often form these tertiary lymphoid structures.
So it's basically a highly structured, immune-rich scar that serves as histological proof that the immune system successfully recognized and destroyed the antigen.
Precisely. The architecture of the scar tells the whole story of the immune system's victory.
Okay, so the architecture tells the story locally. But now, if we zoom out from that localized, microscopic spatial heterogeneity, the starry sky fragmentation we just talked about,
Right.
and we look at the systemic scale, the narrative actually gets much darker.
Yeah, it really does.
Because in head and neck cancer, the primary tumor in the oral cavity is really only half the battle. The lymphatic drainage to the cervical lymph nodes dictates the patient's ultimate survival.
And the paper reveals a truly terrifying discrepancy between these two anatomical sites, a phenomenon they call compartmental dissociation.
Compartmental dissociation. Let's break that down for the trailblazers listening, because it sounds intense.
It is. The clinical implications cannot be overstated. When we evaluate the primary tumor site alongside the resected regional lymph nodes from a neck dissection, we frequently observe completely discordant biological responses to the exact same systemic immunotherapy.
So, wait. Are you saying a patient can achieve a flawless, 100% pathological complete response at the primary site in the mucosal tissue,
Yes, completely clear primary.
while simultaneously harboring cervical lymph nodes that are packed with viable, proliferating metastatic carcinoma?
Yes, exactly that.
But that structural discordance defies basic logic at first glance.
It does. It's incredibly frustrating for clinicians.
If you administer a systemic PD-1 inhibitor, and it successfully unbreaks the immune system enough to completely eradicate a massive primary tumor, why does that exact same circulating immune army hit a brick wall the moment it enters the lymph node?
It's the million-dollar question.
The drug is systemic, the T cells are systemic, why the localized failure?
Well, the failure is rooted in the unique, localized microenvironment of the lymph node itself.
Okay, what's going on in there?
Lymph nodes are not just passive anatomical filters, They are highly dynamic immunoregulatory organs. The authors synthesized data showing that metastatic lymph nodes actually cultivate independent, highly immunosuppressive stromal niches.
So when squamous cell carcinoma cells colonize a lymph node, they fundamentally alter the local cellular neighborhood.
Right, specifically by recruiting and reprogramming macrophages.
Oh, wow. The tumor essentially hijacks the local security force.
That is exactly what happens. Rather than acting as phagocytes to clear the tumor, these macrophages are functionally polarized into an M2-like phenotype.
And what does that M2 phenotype do?
They start secreting massive amounts of immunosuppressive cytokines, things like TGF-beta and IL-10.
Basically shutting down the immune response.
Yep. They also upregulate arginase, which depletes the local microenvironment of the amino acids that T cells desperately need to survive and function.
So they create a localized biochemical force field.
A force field. That's a great way to visualize it. This altered macrophage polarization completely disrupts the normal immune stromal crosstalk. It induces profound T-cell exhaustion, upregulating inhibitory receptors like TIM3 and LAG on the infiltrating lymphocytes.
So even though the systemic immunotherapy is circulating in the blood,
Right.
and even though the T cells physically arrive at the lymph node, they are functionally neutralized the second they cross into that specific nodal compartment.
Exactly. The lymph node basically acts as a fortified safe harbor for resistant tumor subclones.
Well, this mechanism entirely validates why compartment-specific pathology reporting is just an absolute necessity for our trailblazers listening today.
Oh, absolutely non-negotiable.
Because if a pathologist issues a blended global summary report stating, oh, the patient had an excellent pathological response.
They are actively obscuring the most critical piece of clinical data.
Right. The multidisciplinary tumor board needs to know that while the primary mucosal compartment is cleared, a biologically aggressive, macrophage-fortified, resistant compartment still exists in the neck.
And clinical management pivots entirely on that compartmental distinction. If the primary is clear, but the nodal disease is highly viable and resistant, the surgical oncologist must proceed with a comprehensive therapeutic neck dissection.
And the medical oncologist will likely need to escalate the adjuvant strategy, right?
Definitely. Perhaps introducing targeted radiation or switching the systemic therapy back to a cytotoxic approach just to overcome that localized immune exclusion. Real-time risk stratification demands compartment-level resolution.
So knowing that these isolated immunosuppressive niches exist naturally drives the next technological imperative.
It does. It forces us to innovate.
If the standard H&E slide only tells us what is dead and what is alive, how do we uncover the biochemical force fields?
Well, the Mauro paper emphasizes that the treated surgical specimen must be treated as a dynamic biological archive.
We have to move beyond just calculating the percentage of RVT.
Right. We have to start interrogating the functional shifts in the tumor microenvironment. The static tissue slide is giving way to dynamic biomarker tracking.
And how are we doing that tracking?
We achieve this by directly comparing the pre-treatment diagnostic biopsy against the post-treatment surgical resection specimen.
Looking for changes over time.
Exactly. We are looking for dynamic shifts in the combined positive score, the CPS, which measures PD-L1 expression across tumor cells, lymphocytes, and macrophages.
Okay.
We also track spatial variations in tumor-infiltrating lymphocyte, or TIL, density. If the TIL density surges post-therapy but the tumor remains viable, it signals a specific type of localized exhaustion that we need to understand.
But human eyes, even like the most highly trained pathologist's eyes, can only reliably quantify so much spatial data.
Yeah, humans have limits. That's where the future detail in the paper comes in. It relies on highly computational tools.
We are entering the era of multiplex immunofluorescence, spatial transcriptomics, and AI-assisted digital pathology.
It's an incredible time. We are moving from single-stain approximations to layering dozens of phenotypic markers onto a single slide.
And then using convolutional neural networks to decode the architecture.
Exactly. The integration of spatial transcriptomics is revolutionary because it bridges morphology with molecular function.
Because the AI algorithms can objectively and reproducibly quantify RVT across gigapixel whole slide images.
Yeah.
Right. Eliminating the inter-observer variability that always plagues human estimates.
Right. But more profoundly, multiplexing allows us to map precise spatial immune gradients.
What does that look like in practice?
We can pinpoint the exact coordinates of tertiary lymphoid structures. We can measure the physical distance between an exhausted CD8 T cell and an M2 macrophage, and functionally delineate the immune-activated ecosystems from the immune-excluded zones.
Wow. You know, I look at this computational leap like the evolution of sports analytics.
Okay, I'm intrigued.
A traditional pathology report is like reading the static box score the morning after a baseball game. It tells you the final score, say, 10% viable tumor remaining. It's useful, but it lacks narrative.
Right, you don't know how it happened.
Exactly. Spatial transcriptomics and AI are like having real-time, high-definition GPS tracking data on every single player on the field.
That is a brilliant analogy.
It doesn't just tell you who won. It shows you exactly how the defense shifted, where the macrophages built their cytokine walls, and exactly which biological pathways the T cells used to break through the stroma. It maps the mechanics of the victory or the defeat.
The GPS analogy perfectly captures the multidimensionality of the data, because knowing that a T cell is 5 microns away from a tumor cell versus, say, 50 microns away and separated by a dense band of desmoplastic stroma, that fundamentally alters our understanding of the resistance mechanism.
And when you feed this high-resolution spatial data back to the multidisciplinary tumor board, it enables true, uncompromised precision medicine.
It changes the conversation in the room entirely.
How so? Give me an example.
Well, if the AI spatial profiling confirms a widespread, highly organized immune-related regression bed with complete pathological response verified across both the primary and nodal compartments.
The board can breathe a sigh of relief.
They can. The tumor board has the biological confidence to de-escalate. They can spare the patient the massive morbidity of a radical neck dissection.
And they can comfortably withhold highly toxic adjuvant chemoradiotherapy because the tissue has proven the systemic immune system is fully competent.
Precisely. Conversely, if the computational analysis flags that the residual 10% of tumor is physically barricaded by a dense ring of functionally polarized M2 macrophages and exhausted T cells,
The force field.
right, the force field, then the board knows that standard adjuvant immunotherapy will likely fail.
So they can aggressively pivot.
Exactly. Enrolling that specific patient into a specialized clinical trial, investigating macrophage-depleting agents, or maybe novel bispecific antibodies tailored exactly to that immunosuppressive phenotype.
We're transitioning from anatomically defined surgical margins to biologically defined functional margins.
It is a stunning evolution.
It really is. So let's kind of synthesize the journey we've taken today through Annabella Di Mauro's remarkable work in cancers. We started by confronting the illusion of traditional radiology, where the swelling of pseudoprogression deceives imaging, forcing pathology to step in as the ultimate arbiter of truth.
We then examined the necessity of redefining our core metrics, replacing size with residual viable tumor, or RVT.
And we detailed why the starry sky pattern of immune-mediated fragmentation makes exhaustive, whole specimen mapping essential.
While also contrasting the living, organized architecture of immune-related regression beds with the necrotic wastelands of historical chemotherapy.
Then we scaled up the anatomy to uncover the dangerous phenomenon of compartmental dissociation, detailing how metastatic lymph nodes cultivate their own localized, macrophage-driven immunosuppressive force fields that actively neutralize systemic T cells.
Which absolutely proves why separate compartmental reporting is non-negotiable.
Finally, we explored how the field is upgrading its analytical toolkit, utilizing spatial transcriptomics, multiplex immune profiling, and AI algorithms.
Turning the surgical specimen into a high-fidelity GPS map of the tumor microenvironment, empowering tumor boards to safely escalate or de-escalate post-operative care.
It is a profound modernization of the pathologist's role, moving from a diagnostic endpoint to really being the central navigator of the neoadjuvant journey.
I couldn't agree more.
And trailblazers. Before we close this deep dive, we want to leave you with a final provocative thought to carry into your clinics and labs.
Oh, this is the best part.
The paper hints at the future integration of spatial biology with advanced therapeutic delivery. We discussed how AI and spatial transcriptomics can map out those stubborn, macrophage-driven resistance networks in the lymph nodes with micron-level precision.
The precision to identify the exact coordinates and cytokine profiles of the resistance niche.
Exactly. So consider the logical endpoint of this technology. If we can eventually use an initial pre-treatment core biopsy and AI spatial mapping to perfectly predict the formation of these M2 macrophage force fields in a specific patient's lymph node.
Could we bypass the resistance entirely?
Right. Could we deploy next-generation targeted liposomal nanocarriers loaded with macrophage repolarizing agents, say, an mRNA payload that forces those M2 macrophages back into an aggressive tumor-attacking M1 state and deliver it directly to the lymph node alongside the systemic immunotherapy?
That would be wild.
If we can digitally map the resistance before it hardens and biologically reprogram the nodal compartment in vivo, could advanced digital pathology eventually melt the primary and the nodes so completely that upfront surgery becomes entirely obsolete for these patients?
The ability to preemptively map and engineer the microenvironment to that degree would redefine oncology. I mean, if we decode the spatial resistance, we can engineer the systemic cure.
It is the ultimate promise of precision medicine. Thank you, Trailblazers, for joining us on the Digital Pathology Podcast for today's deep dive. Keep interrogating the microenvironment, keep pushing the boundaries of spatial biology, and never stop questioning the scans. We will see you next time.